My talk today about operative vaginal delivery means ventouse, extraction, and forceps. What the indications of operative vaginal delivery? It may be maternal benefits, short second stage, decrease the amount of pushing, such as in case of cardiac disease, pregnancy, in case of Eisenhower syndromes, history of aortic aneurysm, stroke, concern about potential fetal compromise for prolonged terminal bradycardia, prolonged second stage in the nullipara, no progress 3 hours after epidurals, or multipara, no progress 2 hours or 1 hour after epidural. Operative vaginal delivery incidence about 4.5 of vaginal delivery, forceps less than 0.8, recum extractions 3.7. Nowadays, it's marked decrease less than this, and the success rates equal 99% reflect the appropriate choice of the candidate. Nowadays, marked decrease in the use of the operative vaginal delivery to the degree it's called a lost art. What do I need to know before the attempt of operative delivery? Presentations, positions must lie, stations, presence or absence of asynclitism, clinical pelvimetry, and anesthesia. Regarding the contraindications in the gestational age less than 34 weeks, in cases with bone demineralization process, such as osteogenesis imperfecta, with the fetal head unengaged, if the position of the fetal head is unknown. There is a different type of ventouse. This is ventouse assisted vaginal delivery. Don't apply rocking motion, only steady traction in the line in the birth canal. Stop after 3 ball techniques, and it is times is about 20 minutes. 3 ball, if no progress, stop the trial. This is a different type of ventouse. Kiwi cup, elastic cup, and malmostorm of a ventouse. This is how to apply the ventouse cup. We see here, we search about the flexion points here, and it is near the occiput, and we apply the ventouse cup. Then we started to do negative pressures, and when this cup applied on the fetal head in the flexion point here, except posterior, maintain the right angles. If the head is rotated, remove the cup when the fetal jaw is reachable. So this is here how we apply. We search about the fetal head, we search about the occiput, we apply the cup, and then we start to do negative pressures, and then we start the sleep ball technique. What about the fetal risk? This fetal risk may be the cup, it may be detached, and it leads to occurrence of complication, scalp laceration, cephal hematoma, subgaleal hematoma, intracranial hemorrhage, hyperprolipidemia, higher incidence of cephal hematoma, retinal hemorrhage, and jaundice compared to forceps. A brief history of forceps delivery. We have outlet forceps, low forceps, mid forceps, high forceps. These types of forceps, mid forceps, high forceps, is condemned and not used today. We limit use for the outlet forceps only. This is the methods of application of forceps. We identify the blade, place the instrument like this, and apply the left blade, then the right handed blade, and then we locked. It's called L5. Left first, lower blade, and this is both right and left is locked. So this is how we apply the forceps, short forceps. Check for correct application. Chest suture must be in the midlines of the shank. Cannot place more than one fingertip between the blade and the fetal head. Apply traction, steady traction, downward and then upward. Remove the blade when the fetus crown. As I say before, 3 ball only, not more, like in ventouse. If more than this, stop the trial. This is how we pull. Apply the forceps here with correct positions, and we do downward, backward tractions with the uterine contraction. A risk of forceps includes maternal risk, perineal injury, vaginal laceration, cervical laceration, postpartum hemorrhage, and fetal risk, including intracranial hemorrhage, cephalic hematoma, facial brachial palsy, injury to tissue, and skull fracture. Using both forceps and vacuum, high risk of injury for combined forceps ventouse extraction or cesarean section after failed operative delivery. The weight of the available evidence is against the multiple factor with different instruments. So there is a limited use of forceps today, very limited use of ventouse. There is a limited rule for instrumental delivery, and it needs more experience, need more training, and with strict indications we used again for decrease the incidence of cesarean section. Thank you.